In this particular section, we are going to see the regulation of respiration. Even though I'm going to give a lot of basics on regulation of respiration, this is not the thing that is very important. The more important thing is the abnormal patterns of breathing, which we'll be seeing at the last. So that is what is going to be of more clinical relevance than what I'm going to tell in the beginning. But anyways, so let us learn the basics as usual. The first area that we generally have to know is on the pre-Bodenzinger complex. So this is what we refer to as something called a central pattern generator. Central pattern generator, and this is like a pacemaker for the respiration. It is present in the medulla. So remember, these three centers are the medullary centers. These three centers are the medullary centers. Your pre-Bodenzinger complex, dorsal respiratory group, and the ventral respiratory group. These are the pontine centers. Remember, pontine centers only assist respiration, they fine-tune the respiration. They are not the ones that initiate the respiration, whereas the medullary centers are the ones that initiate the respiration. Clear? Pontine centers are just going to assist your respiration. Like a central pattern generator, which is the pre-Bodenzinger complex, we have two other important areas in the medulla. That is called the dorsal respiratory group. We simply can call it DRG. And the ventral respiratory group, we are going to call it as a VRG. Where this dorsal respiratory group is located, it is located in the area called nucleus of tractus solitarius, or otherwise simply called as nucleus of solitary tract. This is one of the largest groups of nucleus in the medulla. We know that. So the NTS is the one which is going to initiate the inspiration. Clear? It is the one that is going to be helpful in initiation of inspiration. Remember, the pre-Bodenzinger complex, to be honest, the pre-Bodenzinger complex is the one, the central pattern generator is the one that really initiates the inspiration, because that is like a pacemaker. That's where the start of the breathing is. This is the one that is going to initiate inspiration, and this nucleus of solitary tract and the dorsal respiratory group is going to maintain this inspiration. The inspiration that is initiated by the pre-Bodenzinger complex is actually maintained by this dorsal respiratory group. Very important. And again, what about the ventral respiratory group? Ventral respiratory group is located actually in the nucleus ambiguus. Again, it's one of the nuclear groups in the medulla. And this is important for expiration. Very important. Remember, in a normal respiration, take a normal tidal respiration, I already told you, inspiration is active and expiration is passive. Since expiration is passive, this center, this ventral respiratory group will become active only in passive respiration. Otherwise, during normal breathing, this ventral respiratory group will be inactive only. Inactive during normal tidal respiration. But when it will become active is only during the forced expiration. When you are doing a forced breathing, like when you are doing an exercise or when you wanted to breathe yourself out. So during that time, this ventral respiratory group will become active. Otherwise, this will become inactive most of the times. The only thing that will be active is the pre-Bodenzinger complex and the dorsal respiratory group. This is in a nutshell. And then you have another center, two important centers in the pons. One we can call as your apneustic center, and the second one you can call as a pneumotaxic center. So let us put this as a pneumotaxic center, which is located in the upper pons. Then you have something called an apneustic center, which is present in the lower pons. Apneustic center, which is present in the lower pons. This apneustic center is going to stimulate the DRG activity. So where is the dorsal respiratory group? Yeah. So this general function is to stimulate the dorsal respiratory group activity. But what this pneumotaxic center does is going to inhibit the apneustic center. Pneumotaxic center's work is to inhibit the apneustic center. Why this pneumotaxic center is trying to inhibit the apneustic center is to prevent the overshooting of inspiration, which means beyond a certain point you should not, inflate your lungs and your inspiration should not continue. To have a pause, to have a stop at where you should end your inspiration. So for that only your pneumotaxic center is very useful. That is the reason why it inhibits the apneustic center, which in turn is stimulating the dorsal respiratory group. So this is the general mechanisms of how these are controlled. So remember, you have to remember the pneumotaxic center, apneustic center in the pons, which is in the upper and the lower pons respectively, which is going to only assist the breathing not initiate the breathing. Medulla is the one that initiates the breathing. Typically in the pre-Bötzinger complex, the inspiration which is initiated by the pre-Bötzinger complex is maintained by the dorsal respiratory group neurons, and ventral respiratory group neurons is important for expiration, not inspiration. So they will be active usually only during forced expiration process. During normal tidal respiration, your ventral respiratory group will be mostly inactive. We have seen all these things. So what is the strongest stimulus for respiratory drive? There are two stimulus for respiratory drive. One is high PCO2. This is considered to be one of the strongest stimulus, physiological stimulus ever existing for increasing the respiratory drive. But low PO2 also can stimulate the respiration. So which means this is also going to act as a respiratory drive. So we are seeing the drives for respiration. So this also can stimulate the respiratory drive. But the most important thing is this low PO2 becomes very important only in patients who are having chronic increase in PCO2. In patients with chronic increase in PCO2, this low PO2 becomes the strongest stimulus for respiration. Why? Because in chronic increase in PCO2, the respiratory group neurons will develop tolerance against the increased PO2. Over time, they will develop tolerance. Because of that, your PO2 now becomes the strongest drive for breathing. And again, that's a very important point. In routine and physiological states, the high PCO2 is the strongest physiological stimulus for respiration. But in chronic hypercapnic states, where you have chronic elevation of PCO2, since there will be development of tolerance against this high PCO2, your hypoxia, low PO2 becomes one of the major contributors to the respiratory drive. Okay, so how they are actually regulated? What are things that stimulate the respiratory drive and what are the things that inhibit the respiratory drive? So first, there are variety of stimulus. Let us see the mechanical stimuli that stimulate the respiratory drive. Exercise. Exercise will stimulate the respiratory drive. Mechanism, the information to the medulla is going to go by the proprioceptors. The proprioceptors, once they get more active, they are going to stimulate the medulla. That is the respiratory center, so that it increases the respiration. So that's why exercise is a very important mechanical stimulus that stimulates the respiratory drive. What are things that inhibit the respiratory drive? Whenever they ask you about mechanical stimulus that inhibit the respiratory drive, the most important reflex that inhibits the respiration is the Hering-Breuer reflex. This is also referred to as something called a Hering-Breuer inflation reflex. So actually this is one of the protective reflexes. This reflex is the one that prevents the lungs from getting overinflated. That's what this reflex is going to do, and typically mediated by pulmonary stretch receptors. The more they stretch, this reflex will get more active and they're going to inhibit the respiratory drive. So this is actually a protective reflex to prevent overinflation. So maintained by pulmonary stretch receptors, and to an extent it is also mediated by vagal afferents. But remember, there is something called a Hering-Breuer deflation reflex also that is seen only in animals but not proved in humans. This Hering-Breuer inflation reflex is typically proved in human beings, not an issue. Then you have a variety of chemical stimuli also. What are the chemical stimulus that you have? Remember, you have two types of chemoreceptors, central chemoreceptors, because chemical stimuli are interpreted by the chemoreceptors. So you have central chemoreceptors and you have peripheral chemoreceptors. What are the things that are sensed by the central chemoreceptors? One is the high CO2, definitely sensed by the central chemoreceptors. And central chemoreceptors are typically located in the medulla, typically in the posterolateral wall of the medulla. This also is a question. Very trivial questions. Medulla in the posterolateral wall. Yeah, central chemoreceptors. Increased PCO2 and reduced pH. So these are two things that are detected by the central chemoreceptors. But be very, very clear. The increased PO2 or any changes in the PO2, like hypoxia, will not be detected by the central chemoreceptors. Very important point again. Will not be detected by the central chemoreceptors. And what are the peripheral chemoreceptors? They are going to sense this high PCO2 for sure. They are going to sense the low pH also. But additionally, they will also sense the hypoxic stimulus, low PO2 also. This hypoxia, if they ask you who is sensing, it is the peripheral chemoreceptors. Central chemoreceptors cannot sense the hypoxia. I know this is a multiple times asked question again. Clear? And next, what will be the inhibition? For respiratory drive from the chemical side. Very high PCO2 more than 70. Remember, this could be coming as a surprise. Here I told you like high PCO2 is a stimulus for respiratory, but only to an extent. But remember, once the PCO2 crosses this 70 mark, actually paradoxically respiratory will start decreasing. And this is what we refer to as something called CO2 anesthesia. That is also one reason why a COPD patient, once the CO2 rises a particular threshold like 70 or 80, they go for more sleepiness and they will be sleeping all the time, somnolent. At the same time, the respiratory drive will further decrease, resulting in more and more accumulation of carbon dioxide. So that is the reason why the CO2 of 70 is a very important limit, where beyond this, your respiratory drive may paradoxically decrease than increasing. Probably maybe due to your tolerance to the CO2. Maybe that could be the mechanism, but we not very sure. And again, a lot of non-specific stimulus are there, like fever, pain, emotions. All these things can stimulate the respiratory drive. Similarly, non-specific stimulus like opioids reduce the respiratory drive by stimulating the mu receptors. We know that opioids causes bradypnea and respiratory failure. We all know that. And diving reflex. This is something very common in physiology, they will tell you, where sudden immersion of face in cold water will produce a sudden reflex causing sudden cessation of breathing. So that's called a diving reflex. Then BP also has its effects. For example, very high BP may also down-regulate the respiration. So that is also possible. Then certain neurotransmitters also work by stimulating or inhibiting the respiration. Typically, they work on the pre-Boettinger complex and they alter the respiratory patterns. What are the neurotransmitters? Stimulation is done by glutamate. You know, it's a universal stimulating agent in the brain and the spinal cord, in the central nervous system. Acetylcholine, serotonin, substance P, all these things are going to stimulate your respiratory center. And certain agents like GABA, glycine, all these things are going to down-regulate the respiratory center, inhibit the respiratory center. So these are the inhibitory neurotransmitters. So these are the things that control the respiration, right from the mechanical to chemical to non-specific neurotransmitters. We have seen everything. And there is another reflex called J receptor reflex. What do you mean by a J receptor reflex? Actually, this is discovered by one of the Indian scientists called A.S. Paintal. And very commonly, like this question they used to ask me in my first year of practical exam. During physiology practical exam, they used to ask the question because it's an Indian who discovered this. Anyways, J receptor reflex. What do you mean by J receptor reflex? J stands for juxtapulmonary capillary receptors. Juxtapulmonary capillary receptors. Actually, these are nothing but C fibers. You will study neurology more about the C fibers. These are nothing but C fibers that are going to sense this particular stretch. So, what they are sensing, if you ask me, they are going to sense the fluid in the interstitium. Suppose if there is going to be some fluid in the interstitium due to any reason, fluid in the interstitium may be due to pulmonary edema, due to any cause, cardiac or non-cardiac, it may be due to pneumonia, it may be due to sometimes pulmonary embolism. So, any cause, if there is a fluid in the interstitium, this will be sensed by the J receptors and they are going to increase the respiratory drive. And the response will be hyperventilation. And there is going to be increase in the respiratory drive. This is called the J receptor reflex. And this is also a typical mechanism of orthopnea, PND and a lot of things. J receptor is a very important mechanism for getting dyspnea in a cardiac failure patient and any condition that produces fluid in the interstitium. So, if they ask you the full J receptor reflex, it's a triad actually. It happens in extreme cases, not in very mild cases, where there will be hyperventilation, then you will be bradycardia, and because of that you will have hypotension also. And this full-fledged J receptor reflex, this triad is also referred to as something called a pulmonary chemoreflex. Pulmonary chemoreflex. So, this is also called as pulmonary chemoreflex, which is nothing but a full triad of a J receptor reflex. But in general, you will see only one component, that is hyperventilation. That is due to fluid in the interstitium. So, this is called J receptor reflex. There is another component of J receptor reflex. So, whenever this J receptor is activated, there is also a lot of experimental data in animals like cats where they have proven that they can cause sudden decrease in the muscle tone. Because of decrease in the muscle tone, you might develop exercise intolerance. Where this is important, if you ask me, it is important for the people who are living, people who are suddenly moving to the high altitude, where there will be, this kind of small fluid leak because of congestion in the lung, because of high altitude and hypoxia induced damage, which we have discussed in detail about the high altitude related illness in basics of pulmonology section. But in those patients also, this receptor has an implication. Why? Because this J receptor, I told you, is the one that is going to decrease the skeletal muscle tone in lower animals. So we thought this receptor could operate in the high altitude. Because of that, they developed the excess intolerance, which is one of the major feature of an acute mountain sickness. So you can actually relate this J receptor reflex to the people who go to the high altitude and suffer from this excess intolerance in the early period as well. Okay. Now we are moving on to the abnormal breathing patterns. Abnormal patterns of breathing. So what are the abnormal patterns of breathing? So first let us put normal breathing pattern like this. Let us see abnormal patterns now. First is Kussmaul's breathing. So what is Kussmaul's breathing? So I'm going to draw something like this. Kussmaul's breathing is nothing but it's a rapid one. So let me draw like this. So you can see it's a rapid, number one. At the same time, it's very deep and labored breathing. Rapid, deep and labored breathing. So this is what we refer to as Kussmaul's breathing. Typically happens in any acidotic states. Classic example is a DKA, diabetic ketosis, but it can happen in any acidotic states. You can get this rapid and deep labored breathing. So that is typically called as Kussmaul's breathing. Then you can get something called a Cheyne-Stokes respiration also. Cheyne-Stokes breathing also. It's a very classical type of breathing where you have a progressively increased depth of breathing, then progressively decreased depth of breathing, followed by a period of apnea, and again the same cycle will continue. So this is what we refer to as Kussmaul's respiration. So first of all, there will be a period of breathing. In that period of breathing itself, they will have a initial increasing depth of breathing, that is called hyperpnea, and later on they will have a decreasing breadth of breathing sequentially, that's called a hypopnea. Then finally they go for an apnea. So this pattern of initial hyperpnea then followed by decrease in the depth of respiration, hypopnea, this is what we refer to as something called a crescendo decrescendo pattern. Remember, anything that goes up and comes down is a crescendo decrescendo, not only here. So this is a classic crescendo decrescendo pattern, and this is specific for Cheyne-Stokes breathing. And there will be a period of apnea, and this can vary usually, but most of the time, this for a particular patient, this period of apnea and a period of breathing, both these things will be equal in a specific patient, and the duration may be variable. For example, if this is 30 seconds and this is 15 seconds, and it will be the same in that particular patient, or in a different patient, it can be 20, 10, 20, 10 like that, or 20, 20, 20, 20, but anyway, it will be the same. There won't be any difference in the breathing. So that proper pattern, what do you see, the crescendo decrescendo pattern, along with the equal period of breathing and followed by equal period of apnea. So this is what we refer to as something called a Cheyne-Stokes respiration, and the very important cause of Cheyne-Stokes respiration is heart failure, which is tend to be the most common cause. Contrary to the popular expectation that brain injury will be the common cause of Cheyne-Stokes, no, it's actually the heart failure that tends to be the most common cause of Cheyne-Stokes respiration. Then respiratory center damage. As usual, like stroke, you can get. Then in a condition called central sleep apnea also, you can get this Cheyne-Stokes respiration, central sleep apnea. So these are some of the conditions. Then what are the other breathing? You have something called a Biot's respiration. This is also referred to as clustered breathing. Clustered breathing or cluster breathing. So what happens in Biot's is, in Biot's also you will have a hyperpnea, you will have a hypopnea, you will have a period of apnea, then again you might have a hyperpnea, you have a hypopnea, you can have an apnea, and again you can have a hyperpnea, hypopnea, you can have a period of apnea. So what is the difference here? Here you are not seeing, first of all, here also you are having hyperpnea, which means one depth is very deep, and hypopnea, you are seeing a very shallow breath also, and you are seeing an apnea also. In Cheyne-Stokes also you are seeing a hyperpnea, hypopnea, apnea. So what is the difference? First of all, there is no pattern. No crescendo decrescendo pattern. Decrescendo pattern. And the entire breathing itself looks very irregular. There is no regularity. Where in Cheyne-Stokes you saw the pakka regularity you saw. You saw that, in a particular patient, the breathing period tends to be equal to another breathing period, and the apneic period tends to be equal to the another apneic period. But here it's not like that. The apneic period may vary, the breathing period may vary, And it's not like a typical crescendo decrescendo. There is no that progressive increase and progressive decline in the depth of respiration. It's just chaotic. Cannot call chaotic also, it's just irregular breathing. That's what it is. So biots generally tend to be irregular. This is the one that differentiates Cheyne-Stokes from biots. Typically, where you get in biots breathing, usually in raised ICP, very common cause, or any brain damage due to trauma or stroke, or in a patient who is using opioids. So they can also get this biots breathing. So these are some of the causes. Apart from that, you have something called agonal respirations. Agonal respirations is generally called to be pre-terminal rhythm. They have this rhythm before death, and this can continue for minutes, seconds, or even hours before death. So usually before death, this is what happens. These agonal respirations come. How they go is like it's like a respiratory center fibrillation. You can see sudden breath will come. So this sudden breath can be a gasp or a myoclonus type of a breath or a grunting type of a breath. So this sudden kind of breath with respiratory fibrillations is what we called as, like agonal respiration. It could be gas. Typically, you saw the gasping, no? This is one kind of an agonal respiration. So this is actually a pre-terminal rhythm, which means the patient might die, like in some time. It might take even hours also, but it's a pre-terminal rhythm. It's before death. It's an extensive, usually happens in a cardiac arrest, post-cardiac arrest. And this kind of respiration starts within 15 to 60. You can see very regularly in the wards if you're in front of the patient when the patient is dying of cardiac arrest. Within usually 15 to 60 seconds of cardiac arrest, this type of breathing will start, and if you don't do anything, patient will definitely die. This is a pre-terminal rhythm. Then you have something called a rapid shallow breathing. Rapid shallow breathing, I can draw something like this. It's a rapid breathing, but it's a very shallow breathing. Where you can get in severe pain in the chest, typically due to chest injuries and rib fractures. Immediately after post-extubation, again very common, weaning, because they will be a little bit dependent on the ventilator and their muscle will not be immediately become active to take sufficient breath. So they can have a rapid shallow breathing post-extubation during the weaning period and during the weaning period. And pneumonia patients who are suffering from pulmonary edema, obstructive lung disease like bronchial asthma, COPD, severe anxiety, all the things are examples of this kind of rapid and shallow breathing. Very commonly, I need to, as a critical care physician, I'll be thinking about more of this kind of cause only, post-extubation and during weaning. Very commonly, you can see this rapid and shallow breathing. Then you have something called an apneustic breathing. What do you mean by apneustic breathing? Apneustic breathing, you can draw something like this. You will have a deep inspiration, then followed by an inspiratory pause, then a rapid expiration. Then again, your respiration will start. You will have a very deep inspiration, followed by an inspiratory hold, then sudden rapid expiration. So what I can tell is this is inspiration, which will be very deep usually. It will reach a very high point, deep inspiration, which is followed by an inspiratory spasm or an inspiratory hold, which means they hold the inspiration or a spasm for some time, which will be followed by sudden expiration, which will be followed by a sudden rapid expiration. So that is due to damage to the pneumotaxic center in the upper pons. So which means there is nothing to inhibit the apneustic center. The apneustic center will keep on stimulating the respiratory center that's through the dorsal respiratory group during inspiration, and there will be no end for inspiration. Actually, the pneumotaxic center is the one that prevents the inspiration from going too much, and there is a stoppage for inspiration because of the your pneumotaxic center only. Because if that is damaged, especially in the upper pons, you might get apneustic kind of breathing. Typically, this happens in a patient who is having a pontine hemorrhage, and if there is an extensive damage to the pons, so you might get an apneustic breathing. So apneustic breathing, in the sense, it's nothing but you will have a deep and slow inspiration followed by an inspiratory hold, and the patient will go for inspiratory spasm and suddenly followed by a rapid expiration. So this is what we call an apneustic breathing. Happens due to a pontine hemorrhage or extensive damage to the pons. The next thing I want to tell is about something called a congenital central hypoventilation. Even though the name looks a little bit different, one word is very familiar to us, that is called Ornstein's curse. This is also referred to as something called Ornstein's curse, otherwise called as central congenital hypoventilation. So here, it's one of the deadliest things. The patient may get respiratory arrest during sleep. That's the idea. So this is due to mutation of a gene called FOX2B gene. This is also referred to as something called a neuroblastoma FOX2B gene. So this is also a question. So what happens due to this mutation is that the patient will go for a life-threatening hypoventilation. Patient will have severe kind of hypoventilation, especially during sleep. When they sleep, they cannot maintain the respiratory drive. When they are active, they can maintain the respiratory drive. When they are conscious, they can maintain the respiratory drive. But when they are asleep, like normal people like us, they can't maintain the respiratory drive, which means they go for respiratory arrest, cyanosis, respiratory arrest, and frequent arousals. Frequent arousal, because the patient has to wake up to breathe. All this happens during sleep. So what will be the treatment? Treatment is nothing. Treatment must be lifelong positive pressure ventilation. Lifelong PP we have to give like CPAP or BiPAP. I will prefer a BiPAP because it's a central hyperventilation. In case of like obstructive sleep apnea, you can do a CPAP. We'll discuss that later on in detail. But in central hyperventilation patients, it's generally better to prefer a BiPAP rather than a CPAP. That is bilevel positive airway pressure. Okay, so you can go for a lifelong PP. That's the only option that these patients have. Otherwise, you cannot do anything. Even the acquired forms are there, acquired forms are not there. For example, acquired forms of congenital central hyperventilation also there. Acquired forms of central hyperventilation happens in road traffic accidents, head injury, or in severe encephalitis. These are the conditions where you might have acquired forms of central hyperventilation. So these are some of the important things. In the on-dance curse, only one important thing that's going to be asked in the exam is the FOX2B gene. That's the only thing they will ask. Apart from that, they're not going to ask much about these on-dance curse in exam. So this is a very short topic. We have finished about the regulation of respiration. With this, we'll stop this and we'll move on to the next topic, that is on the respiratory failure.